allergy, and then we'll do migraine headaches and fibromyalgia, and that's everything in the notes. So, having introduced it as such, this was an interesting, I don't know to what extent you're aware of this, or maybe I'm the only one who sees it this way, but I think around 1965 there was a big change in the medical paradigm where medicine had previously been based on physiology, and then around, in my opinion, 1965 was kind of the magic number. It went from being based on physiology to being based on pharmacology. It seems like it was around that time that there was some shift in the way doctors were trained and the way they practiced. So sometimes I try to look at articles from around that era, and you'll notice that there's a clear distinction, in my opinion, between the language of articles written pre-1965 versus post-1965. Pre-1965 is considered old Medline, and it's harder to get those articles. But again, I think that there was a shift around that time where doctors went from actually thinking to just prescribing. So here's an interesting article, and you would never see anything really written like this these days. Allergic disease is a manifestation of a fundamental distortion of the mechanism through which the individual adapts itself on a cellular level to a hostile environment. These days, I don't think doctors really think of, medically trained doctors don't really think of, allergy in terms of a dynamic process. They just label it. Like, you've got asthma, you've got allergic rhinitis, you've got eczema, and you're going to have this forever, and it's a disease, and it's idiopathic, it's multifactorial, there's a genetic component, there are undefined environmental components. You're screwed, right? That's the allergy consult. You're screwed, you got to take these drugs. So we're going to talk about allergic rhinitis, asthma, and eczema. And you'll see, as we did yesterday, we'll see how we apply this protocol and how it makes sense here. So again, when we look at inflammatory imbalances and anything, but our focus this weekend is inflammatory imbalances, we're going to see how these connect with gastrointestinal status, hormones and neurotransmitters, detoxification defects, oxidative stress and energy production, obviously centers largely around mitochondrial function. So, these are pictures of common drug deficiency disorders. And that's the quote that I gave you just a few minutes ago. And again, the way that I look at this is just to try to address the underlying cause. So the ultimate question, of course, is why. And so, that's just the way that I've looked at things, and I try to understand why things happen the way that they do. Why did this patient never have an allergic disease, and then they went through a stressful period in their life, and now they're allergic to everything, right? So we can't say it's a genetic disease or a genetic problem, and we can't really, I think it's irresponsible to always say, well, there are undefined environmental factors. Why don't we step up and actually define them? So, and I'll give you some cases as we go through this. At the very least, I can give you my own case, because I was a kid growing up in Houston, Texas. I grew up with a lot of allergies. But later, during a period of my life at the end of chiropractic college, I started becoming allergic to everything. Skin rashes, gastrointestinal problems, and all this stuff, just kind of quote-unquote out of nowhere. And maybe I have my own case in here. We'll go through it and see what we come up with. So this is the way that allergy is commonly viewed. There's an antigen exposure. Obviously, there has to be some type of antigen absorption. There's this hyperactive immune response, of course, contributed to by the previously mentioned genetic factors and undefined environmental factors. And then this patient has some type of allergy or allergic rheumatism, if they have joint pain and or autoimmunity. And for a lot of doctors, I think they kind of think, antigen exposure, immune response equals allergy or autoimmunity, but there's a lot that goes on in addition to that. So it's not really appropriate to just think in that simple linear, 3 or 4 step pathway. We have to appreciate what's kind of going on in the background. And I think these are some of the things that are going on in the background. For example, if we just limit this conversation to food allergy, for example, it's not simply that a patient eats a food, they absorb the antigens, and they have a response, and nothing else is happening. A lot of other things are happening. They've got increased intestinal permeability, and so then the question becomes, well, why do they have that? Remember, we talked yesterday about 6 different causes of leaky gut, 4 of which you can exclude by history, so then that only leaves 2 more. It's either allergy causing leaky gut then causing more antigen absorption. So that can be its own vicious cycle. But what I see and what I treat a lot of times in patients is that they have GI dysbiosis. They've got an imbalance of microbes. So they're having a gastrointestinal inflammatory response, and that's what's allowing the increased absorption of antigens, and then they're developing food allergies. And then once we clear out the dysbiosis, I don't do anything about their allergies at all. I just clear out the dysbiosis in their gut and their allergies go away. So I think that, there's certainly a role there for thinking outside of the IgE and histamine box. Dietary molecular mimicry, that's more relevant to our next conversation on autoimmune diseases. Bystander activation, impaired digestion. So a lot, especially 10, 15 years ago, a lot of us were very interested in the idea of supplementing people, for example, with betaine hydrochloride and pancreatic enzymes to improve digestion. I still think there's a role for that. And there are certain patient populations where you'd want to be particularly attentive to that. These would be patients, for example, with vitiligo. If you work with a patient who's got vitiligo, it's obviously an autoimmune disease. And a lot of those patients will have what's called histamine-fast hypochlorhydria or histamine-fast achlorhydria, which means, remember, since vitiligo is an autoimmune disease and since there's often overlap with different autoimmune diseases, the overlap that you see very commonly with vitiligo is they have pernicious anemia and autoimmune atrophic gastritis. So the other place where you see that, and perhaps don't recognize it, a lot of people don't, but it's in the literature very strongly, in Harrison's textbook of internal medicine, for example. When you're working with patients who have autoimmune thyroiditis, Hashimoto's disease, I'm sure you've got patients who have that. About 30% of them will also have anti-parotid antibodies. So between patients with vitiligo and Hashimoto's thyroiditis, and a lot of times people have both, they often have histamine-fast hypochlorhydria. So those would be patients who you might want to supplement with betaine hydrochloride and or pancreatic enzymes. So then what would be your patient base for jumping the gun on pancreatic enzymes? Usually patients with acne rosacea is probably the best example. So patients with acne rosacea are pretty classically known to have pancreatic insufficiency at a higher prevalence in the general population, and if you supplement them with pancreatic enzymes, you can get some symptomatic relief in their skin lesions. So who else has hypochlorhydria and impaired digestion, which is what I'm focusing on right now? A lot of people, right, because they take drugs. Omeprazole, Prilosec, Tagamet, cimetidine. So what happens to a patient who takes, for example, cimetidine or omeprazole? Right, so cimetidine is a histamine 2 receptor blocker. It's an antacid drug, right? And you can remember it's a histamine blocker because it ends with INE. So cimetidine, antihistamine. So what's the consequence of that drug? Short term, if you're a drug company, you only want to look short term. So these studies are going to be like 6 weeks to 6 months at the max. They never find nutritional deficiencies, right? But when you look at the longer term studies, they find nutritional deficiencies. Of course, the drug's already been approved by then. So what happens when we turn off the stomach?